All right, hello and welcome. Today, we're going to play detective and solve a really common medical mystery. It all starts with something that seems simple, a bulge in the groin. But as you'll see, the clues it holds are surprisingly deep. Let's dive right into the case of the inguinal hernia. So you see that bulge. The first question that pops into your head is probably, what is that? But the really critical question, the one that doctors need to answer is, what kind is it? Because believe it or not, the answer to that question changes everything: the risks, the diagnosis, and what to do next. So let's figure this out. So we're tackling what I like to call a common medical puzzle. Our goal? To figure out the true nature of an inguinal hernia. And this isn't just an academic exercise. Getting it right is absolutely critical for the patient. We're on a mission to tell two very similar things apart. Okay, first things first, let's get our facts straight. What even is an inguinal hernia? Well, think of it like a breach in a wall. It's when tissue that's supposed to stay inside your abdomen, like part of your intestine, finds a weak spot in your abdominal muscles and pushes through. Sounds simple enough, right? Well, it's a little more complicated than that. Because, like in any good mystery, there's a twist. That breach in the wall doesn't always happen the same way or in the same place. And that leads us to our two main suspects, each with its own unique story and MO. So, let's meet the lineup. In one corner, we have the indirect inguinal hernia, and in the other, the direct inguinal hernia. They might look the same on the surface, but trust me, they are fundamentally different. Now, let's start uncovering the clues that tell them apart. Here's the high-level briefing. The indirect hernia, that's our most common culprit. It's often congenital, meaning it's caused by a pathway that was supposed to close up after birth, but just didn't. The direct hernia, on the other hand, is what we call acquired. It's not something you're born with. It develops over time as abdominal muscles get weaker. All right, any good detective knows you have to build a profile of your suspects. So let's start gathering the clues on each of these hernia types. By comparing their typical characteristics, you'll see a pretty clear picture start to form. Okay, let's look at the rap sheet. Indirect hernias, they can show up in young people, even kids. But direct hernias, you almost always see those in older patients. And get this, even their shapes are different. The indirect type tends to be more oval, kind of pear-shaped, while the direct one is more round, like a ball. Now, here's a huge statistical clue. Sometimes these hernias can show up on both sides of the body at once. We call that bilateral. And if that happens, the odds are it's a direct hernia. Look at the chart. It's bilateral more than half the time compared to only about a third of the time for indirect ones. That's a pretty big tell. And where the hernia goes is super important. An indirect hernia can actually travel all the way down into the scrotum. A direct one? Nope, doesn't do that. But look at that risk level. This is critical. The indirect hernia has a narrow opening, a neck, which means there's a higher risk that tissue can get trapped. That's a serious problem. The direct hernia has a wide neck, so complications are way less likely. Okay, so we've got a pretty solid profile now. Based on age, shape, and where it goes, we can make a really good guess. But in medicine, you can't just go on a guess. You need proof. So, how does a clinician crack the case with 100% certainty? Well, the answer isn't some high-tech, expensive machine. It's actually in the power of a couple of simple, elegant, hands-on physical exams. These tests are like the final interrogation that makes the suspect confess. It's how we'll solve this mystery for good. Our first technique is the ring occlusion test. It sounds a bit technical, but the idea behind it is beautifully simple. Can you block the hernia's escape route with just one finger? Let's see. Here's the play-by-play. First, the doctor gently pushes that bulge back where it came from. Second, they find a very specific spot called the deep inguinal ring. That's the internal doorway for an indirect hernia, and they press on it. And third, they ask the patient to cough. That cough raises the pressure inside the abdomen and basically dares the hernia to come back out. And here is the moment of truth. If the patient coughs and nothing bulges out, well, that means we successfully blocked its exit. And since we were blocking the deep inguinal ring, bam, we've just proved it's an indirect hernia. But if a bulge still pops out somewhere else, that means it took a different route, punching straight through a weak spot in the wall. Case closed, it's a direct hernia. But you know, a good detective always likes to double-check their work, right? So, for confirmation, there's another great technique called Siemens test.
This one is all about feeling where the impulse comes from. The clinician puts their index finger over that same deep ring, then they put their middle finger over another spot, the superficial ring, which is more like the external exit of that inguinal tunnel. And once again, they ask the patient to cough. The results are crystal clear. If the doctor feels the push against their index finger, that confirms the hernia is starting its journey from the deep ring. It's an indirect hernia. If they feel the impulse on their middle finger, it means the bulge is pushing straight through the wall. Confirmed, direct hernia. It's just a really elegant and simple way to get a solid answer. So, we've solved it. We know how to tell our suspects apart, but there's one last question we have to answer. Why? Why are they so different? The answer takes us a little deeper, right into the amazing architecture of the human body.
You see, the reason for all of these differences, the path they take, their shape, the risk they pose, it's not random at all. It all comes down to the specific anatomical layers each type of hernia has to push through. Think about the indirect hernia. It takes a pre-existing path, a tunnel, called the inguinal canal. As it travels down this tunnel, it gets wrapped in all these different layers of tissue. It's like it's putting on multiple coats for its journey outside. Now, compare that to the direct hernia. It doesn't bother with the tunnel. It just uses brute force and punches straight through a weak part of the abdominal wall. Because it takes this shortcut, it gets covered by a different set of layers along its much more direct path. And really, that's the whole story right there. Two hernias, two totally different paths through the body's layers. This one anatomical difference explains everything we've talked about, why one can go down into the scrotum and the other can't, and most importantly, why one has that dangerous narrow neck with a much higher risk of complications. It's not just a puzzle, it's information that tells a surgeon exactly what they're dealing with.